wellness. This is going to be co-presented by Dr. Melanie Bone and by Dr. Janester Wilson King, MD, both gynecologists and cannabis physicians. Doctors?
Okay, I'm the shrimp, so sorry.
Well, I'm not that far ahead of you.
We sort of want to make this like we're at the Academy Awards. We were going to wear slinky dresses, right? But it's too cold in the room. All right. It's very nice to see that I think more than half of us are women, and that's really great. So we're going to just blaze through some essentials for OBGYN. If I can get this to go forward. Okay, I'm Melanie Bone, and I have multiple hats. My only disclosure is that I do work with a company out of the UK and Bulgaria called Day, and their claim to fame is that they make tampons coated with CBD for dysmenorrhea, pelvic pain. Of course, they got a warning letter from the FDA, and they are no longer selling that product in the US, although they do have the naked tampon, which is just for regular use at Walmart. And they have something called a diagnostic tampon, which you wear for 20 minutes, and you send back and it diagnoses STIs, including HPV, and will assess your vaginal microbiome. Otherwise, I work for the Kesslers, which you will find out in my next talk. And now,
So are we going to switch back and forth? Yeah. Cool. We're going to do this. And we may even throw in a few jokes. Act like we're at the Academy Awards for real. I am Janester Wilson King, MD, fellow FACOG. I'm also a diplomat of the American Board of Obstetrics. I'm medical director and owner of Victory Rejuvenation Center, which is an integrative practice, and I help primarily women age gracefully and balance their hormones, use cannabis, etc. I do have some men because the women send their male partners in because they can no longer keep up with them. I'm also vice president of, there's someone who needs it. I'm also vice president the Society of Cannabis Clinicians, and part of the experts board on Doctors for Drug Policy Reform. And I'll go ahead with our learning objectives. We're going to talk to you about what ACOG feels about cannabis use in obstetrics and gynecology. Then we're going to talk about cannabis in pregnancy, PMS and PMDD, pelvic pain, dysmenorrhea, and perimenopause and menopause. Now, we're going to try to do all of this in 30 minutes. So actually, it's less than 30 minutes now. So thank you for turning over the 5 minutes left sign. We're going to go pretty fast. You can ask us afterwards if you missed something, okay? There you go.
Okay, this slide is merely to show something we've all known. The brain has very little to do with OBGYN. No, I'm kidding. There are receptors in the brain, but as you know, the hypothalamus informs the pituitary, which goes to the ovary, which goes to the uterus, which means that the endocannabinoid system is absolutely essential for anything having to do with reproductive health. Now, Janester's going to cover the pregnancy and the pelvic pain portion. I will do the PMS, PMDD, and perimenopause portion. So let's start with cannabis and pregnancy.
Okay. And I don't generally like to discuss cannabis use in pregnancy because people usually walk away and say, Dr. Wilson King says you should use cannabis in pregnancy whenever. No, no, no. There are certain circumstances, but at any rate, let me stand back here. Yeah, let's do this. Looking back there is just really awkward for me. So, what ACOG obstetrics? No, they don't condone it. There are the most common problem cannabis in pregnancy. And most of the studies are done using smoked cannabis, not the other routes of administration. Lower birth weight, SGA babies, increased risk of preterm birth, and increased NICU admissions. Cannabis does cross the placenta. It does get to the baby. Also, cannabis is in breast milk. THC, CBD remain in breast milk for up to at least 6 weeks. So that old method of pumping and dumping and then breastfeeding doesn't work. So don't bother doing that. The slide says no. We really don't know that, but we haven't seen any to date. There is a position where cannabis use in pregnancy is harm reduction, okay? You can use it for harm reduction, and that should really be under a physician's direction and done in a very physician-driven way, okay? So is that next slide? Did you send it? Okay, cool, thank you. What I'm going to talk about very briefly is the use of CBD, because everybody thinks THC is the culprit, but you can use CBD and all the other cannabinoids, and it's not a problem. That's not necessarily true. But I want to tell you that pregnant women are using CBD in pregnancy. In fact, more pregnant women are using CBD than non-pregnant women. The statistic is 1 in 5 pregnant women will use CBD, and 1 in 10 non-pregnant women use CBD. What are the reasons they use CBD? The same reasons you use CBD when you're not pregnant. Anxiety, pain, depression, headaches, PTSD, etc. Definitely more research is needed, and healthcare providers really, you got to talk about it. You got to talk about even CBD, because you know Florida allows this low THC cannabis to be used in pregnancy, not based on any science. I don't know what it's based on. Next, please. Now, there have been a few studies that have come out in the past couple of years about CBD in pregnancy. The first is an old one, though, that CBD can interfere with placental transport proteins critical to fetal development. There is what's called breast cancer resistant protein. Now it's an odd name. If you want to ask me afterwards how they got that name, I'll tell you. I don't want to take up too much time, but breast cancer resistant protein is heavily on the maternal side of the placenta, and it prevents bad potentially dangerous substances from getting to the fetus. What they do is they carry those substances and put them in the maternal circulation, thereby preventing it from getting to the fetus. So that's one study. Now, the second study they did in rats, and they showed prenatal CBD caused early life heart and brain changes, especially in males. CBD seems to have a gender predilection, and we're hearing more and more studies about the heart, THC even, and heart problems. I'd be careful about that, but I'll explain my take a little bit later. But what they did with these rats, let me say this, all are preclinical. Preclinical. They haven't been done on humans at all. So this study in rats, they gave the rats 3 or 30 milligrams per kilogram, and then measured their heart function at 3 weeks of age, and they found that the cardiac function was decreased, and that there were various other changes in the males. They did the same study with THC, but they also saw that the heart size was smaller, in addition to having lowered cardiac function. Now, this other study was a study that actually showed something positive about CBD. What they did is they gave the rats, they fed the rats a Western, the mothers, a Western diet. Probably the worst diet for health in all the world, okay? So the maternal mice got obese and all that sort of thing. So it does the offspring. That happens in real life too, in humans. So the rats, both males and females, had increased belly fat, and cardiac function was impaired. And in the males, they had increased insulin resistance and insulin sensitivity and insulin levels. The women had more higher triglyceride levels and things like that. So they fed the rats CBD. It was 50 milligrams per kilo over 7 weeks. And they found reduced belly fat and reduced improved functions. And the one thing I forgot to say, neuroinflammation, was decreased neuroinflammation in these rats with the treatment of CBD. So there's some CBD is good. I'm going to skip down to the final one because that study, never seen a study that looked at the minor cannabinoids as well. They too may be detrimental to the placental function. They put CBN, CBC, CBDV, CBG with the placental trophoblast cells and found the viability of those cells. Next. So, you want me to continue? No, I'll continue here. Okay. No, I think it's the other way around.
Oh, well, quick, go ahead.
Okay, all right. Cannabis and GYN, ACOG says yes. They have no problem with women using cannabis for dysmenorrhea, PMS, PMDD, all those other things, and women are really happy to use it. Because one thing I do want to share, women's health conditions are not just in the body, okay? It's not just the pelvis. It affects mood, anxiety, sleep, hormonal changes. It affects the whole body. Cannabis is probably the only treatment plan we have that will cover all of those things as well. So that's very important. There you go.
So now I will just quickly flip over to probably, in my opinion, the most common reason why women will walk through your door to seek cannabis for a gynecological condition, PMS, PMDD. Well, first of all, what's the difference? So PMS is kind of a milder version of PMDD. They both share a lot of the same characteristics. As long as they start in the luteal phase, meaning after ovulation, something important here, your patient needs to have some fairly normal menstrual cycles to be able to know when ovulation happens, to know that they're starting their symptoms in the later luteal phase. But the key element to either PMS or PMDD is that by 48 hours after the onset of menstrual bleeding, it goes away. I mean, it really goes away. So in women with PMDD, they'll say, I become suicidal or homicidal, and then it's like a light switch. A day after my period starts, I'm a new person. That one really has PMS, PMDD. Currently, our way to treat is simply to use SSRIs. But they're not expensive and they work really well, and you can use them episodically. But there are many women who don't like them, can't tolerate them, and for those women, cannabis offers a very nice alternative because remember, these women experience psychological, physical, and emotional symptoms, and so it's a way you can address a lot of them at one time. Mood, for example. Anger is a huge component of PMS, PMDD. I want to kill myself or I want to kill my husband. All right, that's not a good spot to be in, but they can use their cannabis and it brings down their anger tremendously, as well as their anxiety. And by the way, we all know what a lot of women do when they become anxious and angry. They turn to their friend the bottle of Chardonnay. And so it's a substitution issue where I think it's much healthier for them to use cannabis than to drink a bottle of wine each night, which is really not unusual. As far as physical symptoms, I do believe that they have less bloating, cramping, and pain. And in the long run, if we can get them to decrease their use of benzodiazepines, narcotic pain medication, and improve their sleep, we're going to be in a better spot. But the second, or maybe also a very common first reason, is pelvic pain.
And yes, pelvic pain is a common part of health conditions. Besides all the other things, pelvic pain is probably pretty predominant. And these studies that I'm going to tell you about very briefly were looked at endometriosis, which is secondary dysmenorrhea, the most common cause of secondary dysmenorrhea. So we have to look at and all the other conditions to see if these hold as well. I'm betting they do. One of the things that were found is that, endometriosis, like I said, is a systemic disease, and there's migration of the cells. They can even migrate to the lung. Was consulted on a patient who had a lung mass. They biopsied it and said it was endometriosis, so I was consulted. GPR stimulates these cells. It also stimulates the migration of endometriosis cells. CBD is an GPR18 antagonist, so it can prevent that. Then in which they did biopsies, peritoneal biopsies. All these women were undergoing laparoscopies, those who had chronic pelvic pain and those who didn't. And they found that the chronic pelvic pain patients had significantly increased TPRV1 reactivity. Well, CBD stimulation stimulates TRPV1, another nice aspect of this. Then they did a study in which they did the of endometriosis, implanting the endometriotic implant on the abdominal wall of these rats. It's very sad, but watched them grow. Then they gave these were two different experiments. They gave some THC subcutaneously for several weeks, and they watched the endometrial implants decrease in size. Same with beta-carotene. They used 10 milligram, 30 milligram per kilo dose, and then measured the endometrial implants, and found that both of them, the implants decreased. But however, the 10 milligram per kilo dose decreased it by 52.5%, while the 30 kilo dose decreased only by 30-some%. Indicative of cannabis, less is more. So remember, do not have to use large doses all the time. Thank you, I forgot about that. This is one study that was done, Justin Sinclair of Australia, who I've had the chance to.
Perimenopause just are not at all helpful for women. They get them more confused. But the symptoms of perimenopause, I will tell you, are exactly the same as menopause. And in fact, maybe sometimes worse, because there will be periods when the estrogen levels are normal and they go away. But then they plunge down and the symptoms worsen. At least when you get all the way through menopause, you're at a steady state. And I think it's the fluctuations of the hormones in the perimenopause that make women most miserable. But can cannabis help this? And I think the answer is absolutely yes. Again, mood is a primary issue. Anger, irritability, short-tempered, impatience. These are just hallmarks of perimenopause. And we all know cannabis helps with those things. Again, physical considerations, hot flushes, night sweats. No, I don't really believe cannabis helps those. I believe cannabis might help those indirectly. So, for example, many women will get their hot flash when they're anxious. Well, if you can decrease their anxiety, you might decrease their hot flashes. They think it was the cannabis that decreased the hot flashes, but I think it's more of an indirect effect, not a direct effect on the thermoregulatory centers in the brain. That has not been established. So many studies seem to indicate that women like menopause. Now, for a long time, I was asked to consult for some companies that were interested in looking at cannabis for menopause. And I am, like Janester, data-driven for the most part, and these women came out of UCLA, their husbands worked there, and they produced, I would say, their vaginal suppositories for menopause. Okay? They have botanicals and they have cannabis. And they did one kind for the morning and one kind for the night. And you were supposed to use them twice a day to manage your menopause. They're still available today on the market with no science behind them to prove. We do know you probably do absorb cannabinoids through the vagina. In the prior talk, it showed rectal suppositories to have the highest absorption rate of any, vaginal suppositories as well. And therefore, they're a good way to get cannabinoids into your system. But in my opinion, not a good way to treat menopause. So we only say that cannabis is adjunctive for menopause. I'm wholeheartedly in favor of using hormones, and most of my practice now is consultative hormone work, and I do a combination of hormones and cannabis for women who find that if they've tried hormones as their primary management and they don't have hot flashes anymore, but they have incomplete management of their mood symptoms, adding cannabis can be great. On the other hand, I have women who want to use cannabis first, and then they come to me and they say, but I'm still having painful intercourse and hot flushes, and night sweats, and we add the estrogen afterward. So the combination happens to be great. So in summary, I think Janester and I both believe that OBGYN is a wonderful place to be, especially if you practice both cannabis and allopathic medicine, because you can use both your skills to help women to be in a better spot, right?
That's exactly right. I agree with you. Few things I want to say. Thank you. Recommending physicians, you need to discuss women's health conditions. We need to discuss cannabis and pregnancy in females of reproductive age. You have to talk about it. If you don't think it is all right, because you didn't say anything, must not be a big deal. So you do have to bring that up. That's really important. Give them the pros and the cons. The pros and the cons, and explain harm reduction. That is important. Most of the cannabis use in pregnancy studies say if you stop using at the first trimester, or certainly less than 20 weeks gestation, you don't have significant adverse outcomes. It's almost like a normal pregnancy. But I wouldn't even encourage it unless it's something that is needed. Can't hold food down, can't gain weight. The other issue is for women's health conditions, there needs to be more studies, more clinical studies. Also, please remember CBD is not totally benign, even though all those studies were preclinical. CBD you have to ask patients about their CBD use as well, because they think if they're not using THC, no harm. We have to tell people the truth so that they can at least make informed decisions and choices. Thank you.